recentes iniciativas, o professor Subramanian irá hoje discutir conosco a importância de pesquisas e ações em saúde que não apenas foquem em comportamentos individuais, mas, sobretudo, investiguem e ajam sobre aspectos sociais e também estruturais da sociedade. Eu estava mesmo comentando há alguns dias com o professor Subramanian o quanto que a epidemiologia brasileira carrega consigo esse compromisso de produzir conhecimento para, de fato, a gente transformar a sociedade, transformar a saúde da população. Essa é uma característica muito importante, estruturante da nossa área, né? E sempre lançando o olhar da equidade. Então, é vital ampliar em nosso país esse entendimento que nos é comum, de que nós precisamos propor e agir de modo estrutural na sociedade e fazer um enfrentamento radical das desigualdades para realmente dar um passo decisivo na melhoria da saúde do nosso país, né? Caso contrário, mesmo oferecendo os nossos melhores quadros, dando o máximo da nossa força, das nossas energias, nós não chegaremos nem perto de ser o suficiente em produzir essa melhoria tão sonhada pela saúde coletiva brasileira. Quem verdadeiramente vive não pode deixar de ser cidadão, né, e de se posicionar também, já dizia o Gramsci há mais de 100 anos atrás. Então, por isso nós vivemos, por isso nós sentimos em nossa consciência todos os que estão a pulsar conosco a atividade de ter uma saúde coletiva bastante forte, produzindo uma saúde melhor para a nossa população, né? É por isso que nós somos militantes da saúde coletiva e buscamos uma epidemiologia que melhore a vida do povo brasileiro. Então, tomando por base as análises sobre a sobrevida da população infantil no mundo, o professor Subramanian irá brevemente percorrer a história, mostrando os nossos avanços e desafios nessa história, e também irá focar, sobretudo, em dados dos países de baixa e média renda. E também vai discutir a importância de enfrentarmos fatores estruturais e modificáveis com impacto em saúde, e também a importância de indicadores de saúde para basear as decisões políticas dos indivíduos. Assim, eu passo a palavra agora ao professor Subramanian, a quem eu já agradeço a disponibilidade em estar conosco. Subo, the stage is yours. Thank you very much for sharing your time with us.
Okay. Hola. Thank you so much for having me here. And I'm going to start by first thanking Abrasco and Professor Boeing and Professor Alexandria for inviting me here to be part of this gathering. This is my second time I'm visiting this particular Congress, Epidemiology Congress, the first one being in 2017 in Florianopolis. I also want to start by apologizing that, I am, unfortunately, I don't know Portuguese. So my talk is going to be in English. But hopefully, this should work. Next time if I come again, then I'll make an effort to add a few more to the vocabulary that I currently have. So what I'm going to do, because I am standing between dinner and the whole long day that you've had here, right? So I'll try to kind of make it purposeful and hope to have your attention. So over the next 45 minutes or so, I want to sort of focus on one issue of the child survival agenda, globally speaking. When I say global, by and large, what I will present will relate to low and middle income countries. By and large, but some of the issues may still pertain also to high income countries. And what I'm going to sort of focus is on three aspects. One, where do we currently stand with regards to our goals to reduce the preventable mortality amongst early years, soon after birth? So what is our current status? And that is kind of important because most countries have signed on to this 2030 Sustainable Development Goals. And so we are about 7 years out to realizing that if we are really serious about it. Second, I'm going to talk about what's missing in the current global discourse on child survival and also generally on child health, I would say. And lastly, I will conclude by probably, we don't have to reinvent the wheel as if we don't know what to do. So I will close this talk with some remarks about what we can learn from things we have done 100 years ago, mostly in rich countries, that perhaps, and how that differs from the approaches that we are currently taking in low and middle income countries. So that's basically the outline of the talk. Let me start before showing you the current status, just to give you a why worry about child mortality. I think for sure, in Brazil has made remarkable progress over the last 25 to 30 years, especially in bringing it down. But in a vast majority of the world, it's still a huge problem. And amongst that is India. So if India does not solve this problem, then it will remain a global problem, simply by the math of it is just, the numbers are just staggering with 1.4 billion people. So let me start by why child mortality. Here I'm just showing you, on the x-axis is the age, so youngest to the oldest. And this is the sort of the annual death rate, thank you. And it is remarkable that as soon as a child is born, the risk is very high still. It is nearly as high as you reach almost 50. So we should not take this for guaranteed that, if we have reduced, we will stay there. This is from the United States, the Age Mortality Association from 2020. It's a group, it's a pooled data. So kind of child mortality, of course, it drops dramatically as the child survives every additional day and probably even an hour. But it starts at a very high, okay? It starts at very high. And the other point that I want to make here is why child mortality, because that's, we know that life expectancy has gone up. Here I'm showing you various, various cohorts, okay? So the red magenta line is a cohort from 1800, people who were born in 1800, to all the way to people who were born in 1980. This is from Sweden, okay? So what can you see here? We have not made much progress here, okay? But the biggest progress has been in reducing our mortality at early years, and that is why our life expectancy keeps going up, life expectancy at birth. Because life expectancy at later years has not changed as much. Here I'm just picking very select countries. Japan, because it's amongst the longest, along with Hong Kong. United States, that's the country where I live. And amongst the high-income countries, you can probably consider them as the worst. So I wanted to put that there. And then, of course, Brazil. Because that's where I am, and that's the global average, the world. India, because I work a fair bit, and I'll be showing you in Africa. Obviously, I am making a big group here, but there is some variation there you can imagine. But as you can see, it is the reduction in child mortality that actually has led to increase in life expectancy. Nothing much has happened later in the large scheme of things. In the very large scheme of things, this is literally the inverse of that previous graph. This just completely turned this ordering. So countries that decrease their early life mortality improve their life, and this is infant mortality here. And if you just take again, why child mortality? So this is very interesting kind of data on our world in data put together. So for a good chunk of human history, our mortality rates at birth was 50%. And that's true for most of the primates and other species, which would be half the time. There's only half a chance that you're going to survive. And most of the progress has really happened in the 20th century, and actually particularly after 1950. And I'll show you mostly it's a 20th century story. and even more so a latter half of the 20th century story for a majority of the world. Like for Sweden and US or England, it does goes to the early part of the 20th century as well. Okay, so I mean, very quickly, I just want to say that it matters a big deal, and even if countries have lowered it, there's no automatic reason why it will stay low, okay? Unless if those things that we put in place, if they change, our early mortality will change, which will have an impact on the so-called life expectancy gains that we have made. So where do we currently stand? So this is the latest child mortality report from, it's a collection of like agencies led by the UN. I'll come to that in a second. But every year, this is the amount of under 5 deaths. About 5 million kids are dying every year. This is an estimate. I'll come to this point a little later. And every month, that adds to about 500,000. And every day, that adds up to about 15,000 or so. And you can just see it, and a big chunk of that is really neonatal deaths. I don't know if those of you who are not familiar with what is neonatal, those are deaths occurring 28 days after being born, within 28 days. Okay? And people further classify this into early and late neonatal, for those of you who don't work in this area. And the early neonatal is the first 6 days. And then the remaining until 28 days is the late neonatal. So you can see that it's a pretty big chunk. It's still a lot to be done in this particular area. And this just shows like since 1990, I saw a presentation earlier today. Someone mentioned the Millennium Development Goals. And you know, it kind of at 2000 when they started until 2015, but this data comes from 1990. So for every decade, as you can see, the first, 10 years, not decade, from 1990 to 1999 or 2000, about 115 million. The next 10 years, about 85, about 62, and this is only 3 months of this particular, 3 years of this particular decade. And we are at 15 million. So in fact, there is all indications that we are not able to make much more gains than 62 million if you just extrapolate the 15 million for the remaining years, how it's going to go. So we are still be looking at about 50 million deaths in that decade happening if we take that. And this is where we stand with regards to currently, with regards to the goals. The countries have agreed, as per the UN SDG, that the target to achieve by year 2030 for neonatal mortality is 12 per 1,000 live births. Okay, so that's the target. And for under 5 mortality, it is 25 or below for under 5 by 2030. So that's what countries are expected to achieve. And as you can see here, as per this report, about 60 countries are at the risk of missing that particular target. And most of them, as you can see, is in Africa, continent of Africa. And, but when it comes to neonatal, that number goes up, and it is almost like 65 countries are at risk of missing the SDG target. It struck me, this is like when I work in this area. So this is the cover page of that report. The kid seems pretty happy, right? And I couldn't just believe, this is how the report opened, right? I can, because we just went through something called COVID, right? I'm sure people still can remember. I don't remember a picture where there was a happy old man smiling, saying that amount of progress we have made after the vaccine or whatever it was. This was just like, I don't know what to make of it in terms of, I'm sure there are people here who work on the epistemology about this, or, but this when I saw, you wouldn't see a thing like this like 25 years ago on a topic like this. This report has not one negative image. So I don't know, but obviously the numbers are from the same report. So I just wanted to sort of put this out there, when I took a step back, I thought, wow, that's really interesting. You were just patting our own back, right? Look how well we have done. So anyway, I just want to put it out. And this report is like a collective effort of the IGME, which produces estimates, and UNICEF, et cetera, as you can see. Anyway, so what's missing in this current approach to I don't want to say that everything is that, but still it said you're presenting a thing where 5 million kids are dying every year. That is not the picture I would try to put, right? So, but anyway, so what's missing in the current approaches? The first thing I think is this, the industry of counting the dead. You know, in a good part of the world, in a vast majority of the low middle income countries, deaths are not counted. They're estimated, okay? So we still don't know. So estimates means that's like job for me, right? And there's a whole industry on counting the poor, counting the dead. This has turned into a kind of a big exercise. So my first point is we need to confront this straight away, the political economy of the data that is getting produced. In fact, I want to sort of share, I learned yesterday from my dear colleague Sonia, that between 1996 and 2000 in Brazil, there was a very concerted effort to actually count. Not come up with like estimates or surveillance little shops, but real counts. And I think it does matter. So anyway, so that's my first thing. And this is something that we wrote during the peak of the pandemic. I don't want to sort of pitch one against the other from that standpoint, but this is the sort of the worst week of COVID where about 52,000 deaths occurred, okay? Before at that time when I was looking at the analysis. And during that week, if I have to again estimate based on this UN at that point, so there were twice as many deaths happening among kids, unrelated to the lockdown or anything like that, like COVID. It's just sort of generally speaking. And you can really see like more than twice more deaths were happening, but you can search even in places like Lancet and others, you would not see a reference to this happening. But we were getting right down even in like USA Today, how many people are dying every day, okay? But not on COVID. And as you can see, there was a huge difference that has kind of attenuated. Most of the COVID deaths occur in high-income countries. Most of the child deaths occur in lower middle-income countries. So a few questions. So clearly, if action were to be dictated by the sheer magnitude of deaths that is happening, then child survival agenda has no competition, right? It should win hands down. There is just no number is going to come anywhere close in that concentrated time period, globally speaking, right? But it did not. It does not capture public policy imagination. You almost even now have to make this case after case why we need to focus on that. So why hasn't deaths of children evoked the same sense of urgency, right? That the way it evoked for COVID. Just as an example, because now we have a reference to that is occurring at the same magnitude. And one answer could be, okay, like, is it because of the kind of the global discourse tends to favor high-income countries? And there's a lot of truth to that, right? Like Ebola was never covered because it happened largely in Africa, and there's only one American who came close to dying, and even that person was helicoptered out. So most of the deaths happened in Africa, so it was not a big issue. So clearly there is something there that we should confront as we think about it. And this I don't mean to sort of make a personal remark of sorts, but so when there was a whole debate raging whether we should remove the lockdown, because there were studies showing that the services provided to pregnant mothers, services provided to young children were affected because of the lockdown, Okay? Employment took a big hit. And if you're a poor family, et cetera, you're relying. So at that point, there was this whether we should lift the lockdown for the sake of protecting children's lives. Bill Gates made a very generic statement that, if that happens, then we won't be able to ignore the amount of deaths that will go up for COVID. So this is what I mean. So there is a high income, low income. At the same time, Bill Gates donates millions of dollars for child survival, right? But there is an inherent inconsistency in the logic that when it actually comes to it, it doesn't. And I think it really goes back to the key point I want to make it. Those numbers are, because they are estimates, they don't stick with us. Right? They don't stick with us. In COVID, even the lowest middle income country were tracking COVID death. Right? Dashboards were created, Hopkins went on to and it was an amazing collective effort. Yes, there could be uncertainties related to here and there, but an effort was made where every individual anywhere could go to Hopkins' website and get a sense, real time, right? Try that for child survival. Once a year, you will get a report, and you have to average it out, okay? So my first point is, unless and until there is a real count, it's not going to matter, and I don't think we should hide behind this estimates fact. Because that's why maybe people don't take it seriously, because it's an estimate. The second thing is, this sort of is a much more structural issue where civil registration systems are very important. And they're not just important for the business of counting, but these institutions are really important because that's how you build or bring accountability and equity in public health. Because we don't have to build a whole career around, are your numbers right or my numbers right? We should be talking about why are these numbers there, and that should be off the table. There should be a number that it's no longer being discussed as a debate. And this is the one thing, you're just counting. It's not even cause of death. I'm just saying just count the deaths. And I think kudos to Brazil for doing it. Japan did it in 1900, I was told when I was sharing something with a Japanese colleague 120 years ago, when they counted every single birth and every single death. New York did it, I'll talk about it later. So I think unless and until we really confront this issue and stop this business of producing statistical estimates, and that includes me too, we are not going to take it seriously, It's sort of, that's when accountability will come. Okay, so that's my point number one. Point number two, what needs to change is this topic that I'm going to talk about, as I just learned in my conversations with a couple of my colleagues here, may not apply to Brazil directly, but I work on India a lot, so it applies there a fair bit, and it also applies to the country where I live, which is United States. So how do you bring political synergies and accountability into these kind of issues, and can data science approaches help, okay? And this, as I said, is somewhat sort of unique or specific to, right now, to my understanding, at least 3 countries, India, United States, and UK. So in most of these countries, the population health data, et cetera, whether by the census or by administration, is released at what is called as an administrative area, okay? In the case of India, it would be called districts. In the case of United States, it would be counties or census tracts, et cetera. And these are administrative units. And what happens in these countries is, so there is an administration there that is collecting data, releasing data, collating it, doing policies, et cetera. Those boundaries do not correspond to the boundaries from which people elect their representatives, either at the, what you just saw in the US, the congressional level, in those who go to DC, or also the state congressional boundaries. They don't, and the same thing in India, the districts do not correspond to the parliamentary constituencies from which people elect. So the member of parliament is serving a different set of population from the district. And data never gets released at the electoral constituency level. And this was something like, at least in the case of India, that I felt that there's a disconnect here when something like that happens. And my personal sort of learning over the last 5 or 6 years working on policy-related issues in India is that, administrators who are appointed, they really don't have a skin in the game, right? So whether that district experiences a high or low mortality, their job is not going to be in trouble. Because, they are tenured bureaucrats in the case of India. They are selected through a very rigorous exam, et cetera. They are very smart, but there is no accountability. It's an administration, and so I feel like one could argue that we want those kind of people because of efficiency reason, but at the same time, that can be very much directly in conflict with are they truly serving the needs of the population? Because that doesn't often happen. So, in my interactions with my administrative colleagues who are very powerful in India at the district level, they often criticize me, oh, Subbu, you're coming from Harvard, you're writing about all this, et cetera. And I tell the same thing, okay, what skin in the game do you have, right? I mean, I can understand the member of parliament can lose his seat, or she can lose the seat because she has to face the public again in 5 years' time. But the administrator does not. At the most, they will be transferred, but job is secure, right? So I think, I feel that at least in societies where this is not, I'm told in Brazil, it's like much more concordant. The administrative unit where you'd get data and the electoral, they are mostly the same. It happens to be also true in South Korea, where the administration and the political representatives are much more serving the same population. And I think one should treat those geographies as a kind of a more natural unit, because you can actually bring, again, accountability. And I think from a governance perspective, at least in a democratic setup, that's kind of a much more of a natural unit. And this is something that, I was working with the Indian government. This is just the Indian Prime Minister. India just built a brand new parliament, spending a whole loads of money, but at least, but this is a sentiment, right? It is supposed, these members of parliament or the congressional representatives, more than the president, is supposed to be the one who's going to deliver for the population that elected them, right? At the local day-to-day level. And issues like health are very local. Issues like health, issues like education, they are typically not fought at the national level. They are fought much more at the local level, those issues. And I think it can be very helpful in the following way. One, because it brings political accountability, as I said. Second, I have often heard administrators or academics sometimes making an assessment, oh, there's a lack of political will. This is a very standard argument if you're not a politician to say, oh, why this thing is not changing? Oh, there is no political will. But if you start providing data at that point, it's a little hard to hide behind that fact, because if data is given every day on that the constituency that the member of parliament represents, that this is what's happening, it's very hard to ignore. So you can overcome that kind of a lack of political will, apathy, or attitudes. And lastly, but not the least, this is my other learning on public policy is, I feel like more than working with public policy makers, I find that there is no substitute to improving the public's general literacy on policy issues. Then it will sort of change, and data could play a role in that process, where one could potentially discuss these in a much more informed and meaningful manner. And if those of you who want to, so we wrote this sort of call for action one of the authors there that you see, Dr. Amar Patnaik, he's a member of parliament, so this is what, it takes time, but then we ended up doing this as a proof of concept for the parliamentary constituencies of India, if you're interested, and we published this call of action, and that has a dashboard too. If you want to just see for about 33 indicators how Indian parliamentary constituencies are doing. So for example, India as a country may be on track to achieving some goal, but that doesn't mean that every district or parliamentary constituency is on track. To put that in perspective, so neonatal mortality, for most part, India is on target. This data is slightly different from the report that I showed before from the UN, but according to this data, India is mostly on target to achieving as an India level unit. But if I show that by parliamentary constituencies, almost like 200 districts are totally off target of the 700 or so. Okay, so that's very important. I was talking to, again, some colleagues in Brazil. I was saying, like, on perinatal mortality, it will be very important to break this down. Just because Brazil looks okay doesn't mean every population that the country has kind of sorted itself into for governance reason is performing at that level. And this is for under 5 mortality. India is on target again on this, and still about 143, which is the red zones, parliamentary constituencies which are. So it's a very clear thing. If you want to sort of put your resources and other efforts, then that's one way to go, and those are the constituencies. And as you can see, there's a fair bit of spatial autocorrelation that you can see there. And we not only stopped at the national level of parliamentary constituency, so that's about India broken into like 543 members of parliament, okay? But you can get more granular. This is about 4,000, because these are state members of parliament, okay? Every state has a parliament too. And if for issues like education and health and so on, those are much more at the state level, like food security and so on and so forth. But at the national level, infrastructure and so on might be more important. So this is at the level, and what is shown here is for neonatal mortality. So green means neonatal mortality is coming down, so in the right direction, not necessarily that they're on track to, this has nothing to do with SDG, just that they are reducing between 2015 and 2020. But the red means neonatal mortality has gone up, like it's heading the wrong way, okay? So one option is you are heading in the right direction, but not at a rate that you want. You may want to make it fast. But when it flips over to saying, oh, geez, something bad as like going the wrong direction, and that's a little bit of a problem. And this work, I just want to sort of say, like, we had done this paper as an academic paper showing COVID rates by congressional districts in the US, and the Congresswoman Valakue, her office reached out to us saying, can we give her for a different time period that she wanted, because she was chairing the business committee on small business, and they wanted to allocate money into which areas should open up and which areas should not open up, et cetera, to boost the business and the economy. And they requested us, and then we ended up building a dashboard. So which was like, to me, like it did facilitate an engagement, which was much more directly with them rather than dealing with an administrator and having a more academic discussion. And we did this thing at the congressional district for the life expectancy following that encouraging remarks that we got on COVID, which we published. There's a dashboard that we built. And lo and behold, I was not expecting this to be picked up by anybody, but it was interesting that one congressman picked it up, and precisely to say this point that why certain areas should have a better shot and why some areas should have a worse opportunity at like literally basic things like health and education. So to me, I think like at least there is some evidence. Now, understandably, like in the US, like each congressional representative have a pretty decent office, you know. They have staffers, they have researchers as a part of that. But it was, at least to me, it was very much more fulfilling to work with the congressional staffers because you can actually get things very quickly moving with data because, you know, it helps for them to make the case for their constituency. Anyway, so, you know, Kofi Annan made this editorial many years ago on a paper similar, like on importance of showing something geographically, and I thought his quote of if you can, so we have never seen this electoral constituency before, so of course, there's no way you're going to have political accountability come in. So I thought it was a very apt quote. My third, there are two more here, and then I'll close. The third is like, you know, how do you target? Because, you know, when we think about child survival, obviously the risk is not spread evenly, right? And one of the things that I want to motivate is when we look at child survival or child mortality or early mortality, whether it's neonatal or post-neonatal, we tend to, epidemiology, we are here in the epidemiology, our favorite measure to study that is prevalence or risk, right? We rarely even go to absolute risk. We love relative risk, okay? So it's usually a kind of a risk. We don't pay enough attention to burden, okay? So this is a very different, the burden, so when we do prevalence, it's all the population is denominator, and those who become the case becomes the prevalence. But in burden would mean the denominator are the deaths, and let's see how the deaths are distributed, right? So this is a very important point that, at least as an economist, as a policymaker, I would argue the burden argument is much more important for a policymaker because I get the head count, how many deaths are happening, and how that is distributed. Both are important, but I think if we want to make a substantial progress, risk information and percentage and prevalence is a kind of a futuristic. We want to get it down. But right here and now, I want to reduce the burden, right? How many people are dying, and I want to reduce that number, and who are they? So along those lines, I've been thinking, and we identify, at least to our mind, we have not seen that much, with the exception of the first point, focus. That one that actually is very low in terms of the exposure is not very highly prevalent, but a lot of deaths are just happening in that group, okay? So it's a high burden. It is a high risk, but equally a disproportionately high burden. So, you know, I want on the first one, we know that if, you know, this arbitrary way in which we have defined under 5 deaths, nothing magical happens when the child turns 5 years and 1 day old or 4 years and 6 months old, right? I don't know who came up with this, but that's what it is. Same thing with the IMR. So all these, I don't know what's the origin of this, because I have tried to search a lot to see is there a clinical evidence where all of a sudden at 9 months things suddenly drop. Because as you saw, the age mortality relationship is like a Nike swoosh, you know? That's how it goes. And obviously there are periods, but I don't think we should get hung up. But the other 3 I have not seen much being discussed in the literature. One is children who are not weighed at birth. This is a pretty substantial exposure. Twin birth, I'll show you some results. I was shocked to see that, at least in most of the high-income countries, I don't know about Brazil, if a mother is carrying a twin, does that automatically increases her mortality risk, holding other things constant. We found some very troubling evidence for India. And last but not the least, a simple marker of finding a high-risk population, at least we found globally, was whether the mother has ever experienced a neonatal death before. Has one of her prior births, has that resulted in a death, and especially a neonatal death? So this is the point about age. I won't do too much, again, because these are survey data, so you know, it is what it is, but what I just want to show is it's really the first 7-day story. That's the ENMR, which is the early neonatal mortality. Then the late one is from 0 to 6 days is the early, 7 to 28 days is the LNMR, and then we have early post-neonatal, late post-neonatal, and 3 years of child. Okay, year 1, year 2, year 3, up to 5 years. So as you can see, like really it's the high, and of course in many low middle income countries, there is a bump that is coming at about 6 months. And likely because until about 3 to 6 months, probably the kid is getting something and is more linked to the mother, at least perhaps breastfeeding. For example, in India, it's pretty high. And then a real world hits, right? Food security and all health care, access to, if the child has diarrhea, are they able to go to a doctor within 24 hours or 48 hours? So you see that bump on the third bar, which is at 6 months, and then again it starts dropping down, okay? So anyway, my point is I think we should look at more of this as a continuum with the additional focus. And that seems to be the case for most of the countries here. As you can see, the red one accounts for the biggest chunk of the burden. Again, I don't want to discount in many countries in Africa, et cetera. It's still pretty high, 30-40% are happening after age 1, and I don't want to discount that, but if we want to bring some precision and focus, the neonatal is one place to do so. And this is the second exposure that I talked about, the children who are not weighed at birth. So this is for globally. So there are about 12% of the births were not weighed. Weighing a child at birth is a WHO, whatever, one of their checklists. Okay, and I think most national governments follow that. I'm not in that particular area, but that's my reading or understanding from the literature is. So 12% of the population across those, whatever, 32 low middle income countries, that averages to about 12%. So majority are weighed, okay? And, but they account for 37% of the deaths, 3 times more that exposure. So if we can just target what's happening there, I have multiple stories what could be happening. So that's what I'm trying to say, like it's a sort of a 12%, but they account for almost like 40% of the births. That's a huge return on investment if you focus on this group, right? And what is shown here, look at the odds ratios that we are more familiar with as, that we are looking at. The orange dots that you see here is the effect of low birth weight, which we all know is a risk factor for early neonatal mortality, right? But look at the odds ratios for the kids who are not weighed. That's like going into like double digit. That's like 2 times more than what you get for smoking and lung cancer, okay, or thereabouts. That's a very, very high, both risk and a huge, no wonder it's a huge burden. And what we show here is this is true in every wealth quintile. You know, I don't want to call it wealth, but some kind of a SES measure, high SES, quintile 5, low SES, socioeconomic status, and you pretty much find that consistently happening. Okay, so this is a good group, high-risk group. Well, maybe that's one thing to consider. The other one which I was shocked, and I would love to hear thoughts here of people who work, twin birth, okay? So only about of all the births, these are the demographic health surveys, about 2% of the births are twins, okay? So the triplets and the quadruplets are very, very small. It maybe rounds up to 2% if I add them, but about 1 point. And they account for 10% of all the neonatal deaths. Okay, so 1% or 2%, so 5 times more, right? So if you can just create a twin registry, because you can know like way ahead of time whether the mother is carrying a twin or not. Just track a little bit more, like 2% of the pregnancies, right? Returns are huge on that. And look at the risk ratio. That's 113 for a twin, and singleton is 19, right? Early neonatal mortality. So it's a massive, massive risk. I don't know, I've not seen that many studies from the high-income countries where with mortality. There are all kind of other risks that I have seen with twins, but not with mortality. I don't know if this holds true for Brazil or not. That would be pretty worrisome, I would say. You know, just getting a twin should not be a death sentence for one of the pairs or both. And lastly, this is something that we kind of stumbled on. The simplest way, not invasive at all, right, is to just ask if the mother has experienced a death before, if she has became pregnant, had a birth, and then it turned out to be a neonatal death. We can have versions of this. Same thing. So only about 8.5% of all live births had where mother said their kid on one of the births did not make it, okay, fully. They're not alive yet, and they died. And that accounts for almost 22%. And in India, it's actually much worse. It's only 2% is the share in the live birth, and it's 20% this is across multiple countries averaged out. So anyway, so my point is, like, you know, maybe targeting based on this kind of a burden exposure, like where are these deaths happening, okay? Not just continuing with the risk information, oh, this is the prevalence, this is the thing. That has some value, but then we really want to reduce the death, so who are dying? And what do they look like, right? So at least this is somewhere to get us started. Last but not the least is the overarching role of social determinants, you know. So this is something that I've worked on, and in most of the literature on child survival, you will see whether it's a Lancet report, and this was a very good paper in JAMA Open, for which they asked me to write a comment. It was a very well done paper where they really, you know, like did some kind of an autopsy after, unfortunately, the child has died to establish the cause of death. Okay, so this paper was about how can we get information on what caused the kid to die. Okay, and the two big ones, which they called as underlying risk, which was a surprise. Why would you call that underlying? I don't know. But from a clinical perspective, maybe that's how they see it. It was basically infection and malnutrition. The top two reasons, and this you can open any of the Lancet, whatever series they have, you will find malnutrition and infection as the two big causes for early neonatal mortality, and also somewhat goes into child mortality. But, so let's take, you know, to call it underlying, at least as a social science, I wouldn't call it underlying, I would just call it a risk factor, right? Because, why? Because if I take infection, okay, so this is something that I was not expecting, you know, so what is shown here are two outcomes. Diarrhea, one kind of a proxy for infection, something is wrong, right? That's why they're having, and acute respiratory infection. So two types of some bug that the kid has got, infection, okay? And this first set of two bars is 1993, and this one is 2021, so a 30-year lag, okay? People with me? And the red is poor, and the blue is rich, to put it simply, okay? Highest well quintile and the lowest. So you can see in 2021, diarrhea prevalence is higher than the rich 30 years ago. So that's like either a 30-year lag or higher. So the poor today are still not at a point where the rich were 30 years ago. Okay, because we see this, but when you actually put it in perspective, that's a 30-year, that's a generational lag you're talking about. And this is not a generational disease that, oh, it's going to, no, this is, we can do it, right? And you see, okay, here, it's either the same or it's a 30-year lag. And if you look at malnutrition, so variable on that would be severe stunting. Look at that. So the rich in 1993 were 16.5% prevalence of severe stunting. Poor in 2021 is 6 percentage points higher. And if I translate that to the number of population, even if that red bar has come down, 40% prevalence for poor in 1993 and 22 OLEC, we can pat our back like how that UN report did. We're making good progress. The actual number of stunted kids probably has gone up because India's population also went up. And it probably went up much higher in the lower incomes. So when you really put that in perspective, the true burden is actually this pretty large, you know. So 30-year lag is not something that I was expecting, you know. And then I thought, I kept checking, and this is what we got. I don't know what situation you have. So, and we looked at what explains this rich-poor gap, okay? Because all the government programs are on this maternal modifiable risk factors, right? Birth weight, antenatal care visits, drinking water, vaccine, vitamin A supplementation. So those are what I call MRF, so the modifiable risk factor. And the others are more what we would call as the social determinants of health, okay? The one below in the blue bars. So you can really see the modifiable risk factors, this kind of proximal risk factors, what Michael Marmot might call, they only account for 25%. So even if our programs worked excellently, every single program of the government, it would still only account for 25% of the rich-poor gap, okay? So there is a big elephant in the room, which is what when I connected, this was done before I showed you the, now it makes sense to me because that's a 30-year lag you're trying to close, right? So it's a pretty big social story of like just basic poverty and inequality. So the unexplained component is pretty huge. And when we look at mortality, it is exactly the same picture, a 30-year lag or more. Look at early neonatal mortality. Again, like if you see the poor in 2021 are still much higher than the rich in 1993. Same thing when it comes to child mortality. And in these two, it's about the same. You know, they have just about made that 30-year. They're still far behind, but they have at least caught up to where the rich were 30 years ago. So that's what we're talking about in terms of progress or lack of it. And we see the same thing across multiple countries. Those data were for India. Last slide, sorry. So can we learn from history, you know? This is not like we are trying to deal with Alzheimer. We truly don't know what to do because we are living to that age. So there's a genuine part of no one has been there, right? Sweden hasn't been there. No, we can't look at some other countries and say, hey, how did you solve your dementia problem, right? Or Alzheimer problem, because there it's a completely a new kind of frontier if you think about as a disease, or some aspects of mental health, right? As societies have changed, different things have happened. No one has been there before, okay? But with child mortality reduction, oh yeah, a lot of things we know over the last 100 years that we don't have to like reinvent the wheel. And I just want to sort of show one of our students, and we did a paper, this is along with my colleague, Professor Nancy Krieger. We looked at US, which as I said, amongst the rich countries, it would be the worst, right? So even if I take that as a benchmark, I think we can still learn a lot that could be of importance to low-middle countries. So this is that line that you see, that black line, that's the infant mortality drop from about 1930 or 19 whatever it is till about 1960. Okay, that's the data on infant mortality. And you can't see, I'll just show you. These are the things that were put in place well before, all structural institutional changes. I'll come to in a second what they are in a different slide. But this is the context that I'm talking about. So the big chunk of the decline, a lot of things happened prior to that. So what did happen prior to that? So there were these 5 key things. So there was sanitation, civil and vital registration, milk purification was one of them, and breastfeeding efforts, medical care, just generally, access and quality, and last but not the least, especially for child, later mortality, not the early neonatal vaccinations, right? And what we have distinguished here, and you can see this in the paper, like structural interventions that are not about individuals. You just change it. It's like a main switch. If someone turns off, all lights are gone, right? So not like dependent on one by one, okay, let's do it at a kind of a micro individual level. And the blue 2 columns is what happened in the US, and this pink or whatever, these 2 columns is what's currently happening in the low middle income countries. The big take home from there is you see a very explicit and or narrative that you see or discourse that seems to explicitly prioritize demand-side behavior change over supply-side structural factors, okay? And I often sort of, this is something that I've been sort of working on. What's the sort of the, I've been very privileged and fortunate to be able to learn in this field and work in a school of public health. But, you know, and what I have learned is like, at least in the early years, early 2000, and, you know, like the fact that smoking reductions happened in US and other countries, that's always seen as a kind of a success for public health, you know. Vaccines for sure, you know, that was a big one before. But the more new one was the tobacco reduction, at least in the US. After the Surgeon General's report, I think in the late 70s, and we occurred that. And I often wondered, like, you know, but the discourse in the school that I am more open to is like they talk is, oh, we should change the behavior, right? People should not smoke, or et cetera, or if you add other risk factors to it, like eating and sedentary behavior, et cetera, it's all about behavior change. But I often felt that the best example for public health is not the smoking one, or that we reduce that, but it's the air pollution one. You know, there was a classic study, I should probably have, and I was thinking more about it, in 1972 or thereabouts, there was a New England Journal paper called the 6-City Study. And they showed for the first time a link between air pollution and mortality. It was one of the most detailed studies that laid the groundwork for EPA, the Environmental Protection Agency in the US, to start changing main switch. Not, oh, whether can you reduce your emission, or are you recycling? No, you just change the source, right? So all cars had to fit that emission standards. So there was a much, I feel that air pollution, and I'm glad that climate change might provide that framework, that it's not like an individual behavior change thing anymore, right? It's more of a main switch problem. And I think that's what happened when these countries experienced a decline in their child mortality. They put in place a lot of structural factors, and that has served them well since then, which I feel, unfortunately, is not the case, at least in India, where I've studied more carefully, but also the evidence seems to suggest in other low-middle-income countries. With that, I will thank you so much for giving me the time and your attention.
Thank you, Subbu, for your thoughts. Então, depois dessa fala do professor Subramanian, nós encerramos o primeiro dia do evento, agradecendo a todos que estiveram aqui, e certamente amanhã e quarta-feira teremos mais
ótimos momentos para discussões. Obrigado, boa noite a todos.